Hello, everybody. I shall be talking about how to approach the patient with coronary artery disease. Now, it is important to start off by discussing some important medical terms. These are terms that doctors use frequently, but those not in the medical line might not understand them completely. Symptoms are what the patient complains of, the discomfort he or she feels that brings him to see the doctor. Signs, on the other hand, are what the doctor finds after examining the patient. An acute condition is one of sudden onset and usually of short duration. A chronic condition, on the other hand, comes on more slowly and has longer duration of disease. When a doctor talks of symptomatic treatment, he refers to measures used to relieve symptoms, to reduce the discomfort and pain that the patient feels. On the other hand, when you treat a patient prognostically, you are actually treating to prevent future bad events from coming about, such as a heart attack, a stroke, or a death, all of which will, will be occurring in the future, and your aim is to try and stop them from occurring. Now, the coronary arteries transport blood filled with oxygen to the muscles of the heart. Like all living tissue, the muscles of the heart need oxygen, and this oxygen is carried in the blood by the coronary arteries to supply the muscles. When the supply of oxygenated blood is inadequate, then ischemia develops. Ischemia, therefore, is a condition that occurs when the supply is reduced or when the demand for oxygenated blood exceeds the supply. In other words, ischemia is actually a result of imbalance. It can occur when the supply is reduced, such as the coronary flow is reduced, the hemoglobin content is reduced because hemoglobin is what carries the oxygen, and when the hemoglobin in the blood is reduced, then the amount of oxygen it carries is also reduced. Similarly, when the patient does not breathe in enough oxygen, the oxygen content in the blood will also be reduced and the delivery to the heart muscle will be inadequate. On the other hand, if the heart rate goes up, if the blood pressure goes up, then the heart muscle needs more oxygen in order to supply this increased work. And if the supply is inadequate to meet this increased demand, then ischemia will also develop. Similarly, the hypertrophic muscle, the thick muscle or the swollen muscle, will also need more oxygen. And therefore, if the supply is adequate for the ordinary heart muscle, but not for the thick heart muscle that requires more oxygen, then ischemia will similarly result. So ischemia, therefore, is an imbalance in the myocardial oxygen supply and demand. Now, classically, ischemia comes about because the coronary arteries get blocked. The most common cause of myocardial ischemia is coronary artery disease, and that's why another name for coronary artery disease is ischemic heart disease. To reiterate, ischemic heart disease is a problem of inadequate supply of oxygenated blood. It most often comes from the obstruction to coronary blood flow, and this obstruction is usually due to atheroma, a plaque of cholesterol blocking up the circulation of the coronary arteries, and this atheromatous plaque results in chronic stable ischemic heart disease, the acute coronary syndrome, sudden death, or heart failure. Ischemic heart disease can also be due to causes other than the atheromatous block, like if the vessels go into spasm, if there is dysfunction in the endothelial lining of the circulation, because you have to pass through the endothelial lining to get to the heart muscle itself. And so, if there is a problem with the endothelial lining, the oxygen will not be able to migrate from the blood cells into the heart muscle cells. Similarly, there can be problems with the microcirculation. which means these are the small circulatory vessels coming off from the major coronary blood vessels. And when these small vessels are diseased, there will similarly be a problem of supplying oxygen to the heart muscles where it is needed. Myocardial ischemia can also be due to non-coronary causes, like I have mentioned, when there is increased demand for oxygen, as occurs when anemia comes about, the hemoglobin drops, when there is tachycardia or the heart rate goes fast, when there is hypertension or the blood pressure goes up, when the heart muscle thickens, as in left ventricular hypertrophy. So the coronary artery disease or ischemic heart disease can result in chronic stable ischemic heart disease, and this condition can be either asymptomatic that the patient does not know about, or the patient may feel exertional angina. Acute coronary syndrome is a more serious group of conditions due to ischemic heart disease, and patients will present either with unstable angina, the non-ST elevation, myocardial infarction or heart attack, or the ST elevation, myocardial infarction. Now, sudden death can also be caused by ischemic heart disease, but technically, sudden death is caused by an irregular heartbeat, an arrhythmia called ventricular fibrillation, where the heart contracts irregularly without coordination, is therefore unable to pump out blood to the body, and this ventricular fibrillation results essentially in an in inadequate blood supply to the brain, to other parts of the body, and the patient can die. There are many other non-ischemic causes that can bring about this arrhythmia, and we shall therefore not discuss this condition very much today. Similarly, heart failure can be due to ischemic heart disease, but that topic will be addressed in a separate lecture. The important point to remember about the atheromatous plaque is that it is not the size of the plaque that is important. It is the type of the plaque, the type of atheroma that is important. Whether the condition is stable or unstable depends on whether the plaque is stable or unstable. Now, an unstable plaque will have a lot of cholesterol or lipid inside the block. There will be full of lipid. There will be a thin cap or a thin covering for the lipid, and there will be a lot of macrophages or inflammatory cells within the lipid-rich atheroma. And when the plaque ruptures because of the thin covering, the lipid touches the blood, a thrombus forms. On the other hand, a stable plaque has a thick covering, a thick fibrous cap, very little lipid or less lipid in the atheromatous core, less inflammatory cells, and so there is narrowing of the blood vessel, but there is no thrombus formation and no inflammation within the lipids. So for the progression of the coronary artery disease, it is important to understand that a stable plaque causes chronic stable angina, while the unstable atheromatous plaque causes the acute coronary syndrome. So in the ordinary blood vessel, there will be a large lumen and a fairly normal lining to the lumen of the blood vessels. But with age, then the atheromatous plaque builds up, and if the atheromatous plaque is stable, it tends to have a thick covering, little inflammation, and little lipid core. On the other hand, an unstable plaque will have a thin covering, often gets disrupted with lipid touching the blood vessels, resulting in platelet aggregation, thrombus formation, because there tends to be a lot of inflammation and lipid-rich particles within the atheromatous core. The progression of the condition is confusing because while we know that the stable plaque has a thick cap with little inflammation, the unstable plaque has a thin cap, a lot of inflammation, can rupture, and therefore cause acute coronary syndrome or sudden death. Plaques can rupture and then heal intermittently, and plaques can progress, get worse, or regress and get better. so that the stable plug can become unstable, but the unstable plug can then become stable again. So it is not a one-way ticket of a plug growing bigger and bigger, becoming unstable, bringing about death. The plug can progress, but in a stable manner. They can become unstable and then go back to become stable, or at any time the stable plug can become unstable, causing death. So, coronary artery disease is actually a living condition that can change as life goes on, be influenced by what you do in life, by the medication you take. It can progress and it can also regress. Let us then view more in completely and in a more detailed fashion about the two conditions brought about by ischemic heart disease, the chronic stable ischemic heart disease, and the acute coronary syndrome. Now, what is angina? Angina is pain or discomfort due to an inadequate supply of oxygen to the heart, as we said, the ischemic condition, and it comes about because of increased demand for oxygen, such as when there is increased activity, when the patient becomes emotional, after taking food, because after food, blood is needed to go to the abdomen to digest the food. And when more blood goes to the abdomen, there's then less supply to the coronary circulation, and that is where the patient can then feel the pain. Depending on the position of the patient, on lying down, there's more blood flow back to the heart. The increased preload stresses the heart. It needs more oxygen supply. And if there is a block in the coronary circulation, the supply will be inadequate. Similarly, other disease conditions like fever, like infection elsewhere, like pyrotoxicosis, any disease condition like uncontrolled diabetes will all cause the heart to work harder, and the heart that needs to work harder will need more oxygen. And if there is blockage to the flow of blood, there will be an inability of the circulation to supply enough blood to the heart, giving rise to angina, felt by the patient as a pain or discomfort. Now, it is not a sharp pain, it's not a burning pain, a pricking pain. It is always described as a pressure or squeezing pain, noted in the chest, sometimes it goes to the shoulders, sometimes it is in the arms, in the neck, jaw, back, or sometimes in the upper abdomen. So a patient who feels indigestion pain in the upper abdomen is a patient that one has to ask very carefully, because he might actually be having angina. The classical discomfort of angina is made better by resting and by using sublingual nitrates, putting a tablet of nitrate into the mouth under the tongue, let it dissolve so that it is absorbed through the buccal mucosa, and that will promptly relieve the discomfort within 3 to 5 minutes. A patient who uses nitrates and says that the pain goes away half an hour later is unlikely to be describing anginal pain. The discomfort and pain of angina classically is associated with other symptoms like difficulty in breathing and sweating, and the discomfort radiates. So it is important to ask where the pain and discomfort starts and where it progresses to. So it usually goes from the chest to the neck, jaw, shoulder, or arm. Now, the way to grade angina is to use the Canadian Cardiovascular Society classification. In class 1, the patient is able to do ordinary activity which causes no discomfort. Angina only coming on with strenuous, rapid, or prolonged activity. In class 2, there is a slight limitation of ordinary activity, such as difficulty climbing stairs, walking uphill, especially when under stress during the cold weather, perhaps. In class 3, there is marked limitation of these ordinary physical activities, such that the patient will notice the pain after walking 1 or 2 blocks on the level, or after climbing 1 flight of stairs. And finally, for class 4 CCSC classification, the patient is unable to carry out any physical activity or will have angina at rest. What is unstable angina? Effectively, it is worsening angina. So, angina that is of new onset is unstable angina. Angina that was previously felt but of a certain intensity duration but occurs now with less physical activity, or angina that occurs at rest without any exertion, all point towards the development of unstable angina. A more detailed classification of unstable angina says that it should be angina at rest that is prolonged than 20 minutes, that it is not just new onset angina, but it is at least class 3 severity by the Canadian Cardiovascular Society classification, which means that it is angina felt with normal physical activity. Then, new angina that is at least class 3 is a worry about being unstable angina. And any angina that is previously diagnosed but becomes more frequent, more severe, longer lasting, and comes on with less activity, increasing in classes perhaps, then that is a suggestion that the angina is worsening, becoming unstable. It is important to pick up unstable angina because you want to treat it quickly and promptly to prevent the development of a heart attack or myocardial infarction. Now, in myocardial infarction or heart attack, there must be death of myocardial cell. So the definition of a myocardial infarction therefore says that we have to detect a rise and fall of cardiac troponins. Cardiac troponins are enzymes released from the heart muscle when it is damaged. The troponin is contained within the muscle, the cell of the heart, and so when there is damage to the cell dies, the troponin gets released into the blood. So if you find that there is a rise or a high troponin that subsequently falls, then there is evidence that a myocardial infarction has occurred. Note that we want to see a change that is from low to high or from high to low, because a myocardial infarction is a dynamic process, that there must be a change to the level of troponin for us to say that a myocardial infarction has occurred. So a person with myocardial infarction will have a change in the level of troponins or cardiac enzymes together with symptoms, discomfort to suggest ischemic pain. He should also have, or he should have some new ischemic ECG change, or he should have a Q wave on the ECG, or he should have a loss of myocardial function or abnormality in the movement of the myocardial wall on some form of imaging of the heart. Similarly, if by looking at the coronary arteries or at autopsy, we find a thrombus there, then a condition of myocardial infarction can be diagnosed. Now, there are four types of myocardial infarction, but again, I shall not go through it in detail. The classical one, due to the atheroma that burst that allows the lipid to touch the blood, that inflammation induces a thrombosis, is called type 1. Type 2 is a myocardial infarction brought on by a medical condition. Type 3 is where the patient dies suddenly and an autopsy, a myocardial infarction is diagnosed. Type 4 is myocardial infarction after angioplasty and stenting, and type 5 is myocardial infarction after bypass surgery. In assessing patients with coronary artery disease, it is very important to look for the risk factors that predispose the patient to coronary artery disease. Now, these risk factors are things like the age of the patient. The older you are, the more likely you get coronary artery disease. The sex. A male is more likely to get coronary artery disease, and a female, so long as she menstruates, is protected by her hormones generally from coronary artery disease. The race of a patient has some effect on the ability to get coronary artery disease, with blacks and South Indians, for example, being more prone to the condition. The total and HDL cholesterol are important factors. High total cholesterol, low HDL are factors that make a person more likely to get coronary artery disease. High blood pressure is a risk factor for coronary disease, as is diabetes and a smoking history. Now, these are the parameters that make up the pooled cohort equation. And if you go into the internet and look up the online site for pool cohort equation, when you enter in the parameters for all these factors, you are able to come out with an estimated 10-year risk for an atherosclerotic event, defined as either a non-fatal heart attack, coronary heart death, or stroke. So the pool cohort equation, and there are many other types of equations, predicts the likelihood that a patient will get an atheromatous ischemic event based on various risk factors. So in seeing the patient with coronary disease, it is always very important in the history, in asking for symptoms, to look for these risk factors, and in examination to look for the effects of these risk factors on the other body systems. So to repeat, when you approach a patient with coronary artery disease and when you are taking the story, asking for the symptoms of the patient, remember the risk factors. Ask about smoking, whether there is diabetes, whether the patient has had hypertension before, being told that the lipids are high, look at the age, the sex, and whether the family has it. Because if the family has it, then the patient would be more at risk for getting coronary artery disease. Similarly, it is important to get a good description of the discomfort a patient feels. Is it pressing? Where is it? What brings it on? What is the discomfort associated with? And where does it radiate? Because all these factors will tell you whether the patient is complaining of pain from ischemic heart disease or from something else. Look for other atheromatous disease, because atheromatous disease is a generalized condition affecting the whole body. So you must look and ask the patient about stroke, about whether he feels pain in the lower limbs on walking as evidence for obstruction of the peripheral vessels of the legs. Ask for the complications from ischemic heart disease like heart failure, prior cardiac arrest, which means the patient feels abnormal, unwell, faints, and loses consciousness. Look for the complications from the risk factors again, like stroke, like renal damage, like problems with the eyes and peripheral circulation. And in examining the patient, look for complications from ischemic heart disease, like heart failure, whether the patient has had previous bypass surgery or a pacemaker. Look for evidence for other atheromatous disease like stroke. Is there neurological abnormality on one side of the body? Look at the peripheral vascular disease signs, namely, are the pulses from the lower limbs felt? Look for the complications from risk factors, again, similarly, stroke, renal disease, eye disease, and peripheral circulation. So now, in more detail, in the history of the patient, ask about chest discomfort, where it is, what brings it on, what relieves it, what how long does it last, where does it radiate, how frequent does it come on, how disabling is it. Remember to ask the nature of the discomfort, the risk factors that can precipitate a patient to coronary disease. Ask about smoking, diabetes, hypertension. Ask whether a patient is menopausal if it is a lady. Ask about family history of ischemic heart disease. Ask about past history that required admission, and ask about medication intake. Patients taking painkillers, for example, are at risk for developing ischemic heart disease. Now, this is a slide showing what angina pectoris, or the symptom and pain from ischemia, feels like. It is described as a discomfort that is a pressure and a tightness. Some call it burning. It is choking, breathlessness. It is a pain. Some describe it as other sites like the upper abdomen, the shoulder, the arms, neck, jaw, and some describe it with nausea, with sweating, and generalized discomfort. These are the sites where angina can occur, and this slide shows where the pain can go through, up to the neck, to the left shoulder, and sometimes down the left arm. So a patient likely has angina if the patient profile fits. For example, an older man who smokes, who comes from a family of people who have had heart attacks. Now, the discomfort for angina comes with exertion after food, with emotion. It lasts minutes. If a patient has pain the whole day, it's very unlikely to be angina unless he would already be very sick. Its pain of angina is relieved with rest or with nitrates. And pain that is sharp, localized to a spot. If a pain of angina classically has a large area, vague area where it is felt, but if it is sharp at one point, then it is less likely to be angina. A pain that lasts the whole day or just 1 or 2 seconds, again, is unlikely to be angina. And any pain that is worse when the patient presses, when the patient moves about his chest, not so much exerting, but generally turns the body about, is not likely to be angina. In examining the patient, check the blood pressure, check the pulse, look for arrhythmia, is the pulse regular, and look for the heart rate, is the pulse fast, suggesting that the patient is in some form of distress. Remember to assess the state of the peripheral circulation, meaning feel the pulses of the lower limbs. Look for evidence of heart failure. Is there swelling in the leg? Is there elevated jugular venous pressure? Look at the chest for an operation scar from bypass surgery. Feel the apex beat to see if there is heart enlargement or a forceful apex to suggest thickening of the heart muscles. Listen for the heart sounds. A third of all heart sounds may suggest strain on the heart. Look for crepitation at the bases of the lungs because they point to the presence of heart failure. And in the abdomen, look for an enlarged liver, which again can suggest congestion from heart failure. This slide shows the key classification for a heart attack. Now, this is seldom used these days, and as you can see, this comes from more than 50 years ago, but it is shown to show you that you actually can predict the outcome of a patient based on simple clinical examination. Now, a patient with a heart attack but is otherwise comfortable with no evidence of strain or heart failure will have a mortality of 6%. If there is heart failure with crepitations in the lungs, a gallop rhythm, and elevated venous pressure, the mortality rises to 17%. If heart failure is severe, the crepitations is more than 50% of the lung area, then there is a mortality of almost 40%. And if the patient drops blood pressure with peripheral vasoconstriction, oliguria, diaphoresis, cyanosis, then the risk for death goes up to 80%. So it's very important, even in this day of great equipment, not to miss out on examining the patient and looking at how the patient is. And I shall stop here before proceeding on to investigation at another talk.